Assalamu alaikum warahmatullahi. I thank the organizers for inviting me and giving me this opportunity to interact with you all on this topic of management of diabetic ketoacidosis. It's an emergency in children with type 1 diabetes. I think some of you may be working in the pediatric department, but most of you are not exposed to pediatric department. So I will try to keep it as simple as possible, but at the same time to orient you towards this problem so that you are able to understand at least what goes in this particular emergency. So I'm going to firstly briefly touch upon pathophysiology of DKA, definition of DKA as per different guidelines. There are various guidelines which define DKA. DKA means diabetic ketoacidosis. And then finally we'll touch base on how to manage the DKA. So as we all know, in normal situation, what happens is there is glucose in the body and insulin which combines with the insulin receptors, and this ultimately stimulates this GLUT4 receptor, and GLUT4 receptor makes entry of glucose inside the cell, and this glucose then gets phosphorylated into ATP, and extra amount of glucose gets converted into glycogen in the skeletal muscles, and it gets converted into lipids by process of lipogenesis. This is what normally happens. And during diabetes, what happens, particularly in type 1 diabetes? In type 2 diabetes is different. In type 1 diabetes, there is a destruction of the islets of Langerhans, which are producing insulin hormone, or there are autoantibodies against the insulin. So there is basically insulin deficiency, and because of that, this receptor is not working. So when this receptor is not working, insulin receptor, there is no more stimulation of GLUT4, and that's why there is no more entry of glucose inside the cells. So when entry is prohibited, automatically there is a starvation within the cells, and the glycogen is now broken down into glucose, and that leads to excess amount of glucose accumulation outside the cells, okay, because it is not entering inside the cells, and this glycogen itself, because of glycogenolysis, this also contributes to hyperglycemia. All right, and all these things will lead to excess amount of glucose accumulation in the body. And as we know, the osmolality calculation, the osmolality is given by this formula: 2 multiplied by sodium plus potassium plus blood glucose divided by 18 plus blood urea nitrogen divided by 1.6. So if you look at this equation, once the blood glucose level is going up, the serum osmolality also will start rising. So because of that, the osmolality goes on increasing because of high blood glucose level. And in most of the cases, initially what happens, if there is excess amount of sugar in the body and excess amount of water dragging into the body, there can be a spurious fall into serum sodium also. So that's why we need to correct the sodium. So how to correct the sodium? It is said that if for every 100 milligram of blood sugar above the 100 milligram, so you take 100 as your cutoff normal sugar, and for every 100 above 100, you have to add 1.6 into whatever sodium you have measured. So for example, if you have measured a RBS, random blood sugar of say 300 milligram, and your measured serum sodium was 130, so your corrected sodium will be 133 milliequivalents per liter. So this corrected sodium is very important because your sodium is spuriously low because of excess amount of fluid into the circulation because of hyperglycemia. So what happens is, as we saw just now, hyperglycemia, which leads to directly polyuria, as we know, and polydipsia, and as we already saw, it leads to excess amount of osmolality. Osmolality will lead to polydipsia. That means you are going to feel more thirsty and you will drink a lot of water. All these things will lead to hyperosmolality. Hyperosmolality will lead to intracellular dehydration, and this will lead to mesenteric ischemia and pain in abdomen. So this is how the pathophysiology works in DKA, and there is a stimulation of hormone-sensitive lipase, which will lead to lipolysis, and this will lead to excess production of acetoacetyl-CoA, and then there will be excess amount of production of acetoacetic acid and beta-hydroxybutyric acid. So all these are basically ketone bodies, and this is basically keto acid. So that is why we call diabetic ketoacidosis. So there is excess amount of ketone bodies. Also from the muscles there is proteolysis that also contributes to ketoacidosis. So that's why there is hyperglycemia, hyperosmolarity, as well as ketoacidosis in type 1 diabetes. And then when there is ketoacidosis, this is going to stress the kidneys. The kidneys, as a compensation, will start losing a lot of bicarb, and that will lead to depletion of the bicarb and acidotic breathing. and it will also excessively stimulate the chemoreceptor trigger zone in the medulla oblongata in the brain, and that will lead to excessive nausea and vomiting. So these are all the reasons why the various symptoms of diabetic ketoacidosis you will see. And what happens is, when there is excess amount of acid in the body, when there's H plus ion, there's H plus ion, when it is entering the cells, it is exchanged for potassium. So the potassium goes out and intracellularly potassium is depleted. That is why if you measure serum potassium in DKA, you may find that the potassium is 4.5 or 4. You may think that potassium is normal, but the child may be actually hypokalemic intracellularly. That's why they are at a high danger of hypokalemia. The moment you start correcting their acidosis with insulin infusion, which we are going to see in next slides, you will see suddenly the potassium dropping. So that is why we need to be very careful that there is a big risk of hypokalemia, and also because of hyperaldosteronism, there is a risk of hypokalemia in patients with DKA. So now, do you understood what are basic pathophysiology of DKA? Definitions. There are three main guidelines which have given definitions of DKA. The most famous is the SPAD, the International Society for Pediatric Adolescent Diabetes. They define hyperglycemia as blood sugar more than 200 milligram percent, and acidosis they define with pH of less than 7.3 and bicarbonate of less than 18, and ketonemia they define by beta hydroxybutyric acid of more than 3 millimoles per liter. This is how they define, and they have divided it into mild, moderate, severe depending upon pH as well as bicarb levels. Okay, and there is another famous guideline, that is British Society of Pediatric Endocrinology for Diabetes, and they have defined also based upon pH, bicarbonate and beta hydroxybutyric acid of more than 3 millimoles per liter. So if we compare them side by side, there is another Milwaukee, which you don't use Milwaukee guideline much, but we can see for hyperglycemia there is no problem. They all agreeing with each other. Sugars of more than 200, everybody agrees that is diabetic ketoacidosis, diabetes or hyperglycemia. For acidosis, there is some difference. Milwaukee says that when the pH is less than 7.35, and SPAD and BSPAD basically pH is less, same 7.3, 7.3 both. For SPAD, bicarbonate cutoff is 18, and for BSPAD, bicarbonate cutoff is 15. All right, and for ketonuria, ketonemia, and the beta hydroxybutyric acid cutoff is same for SPAD as well as BSPAD. So this is a very important cutoff. You can follow one of them. In our unit, we usually follow the SPAD guideline. So this is easy because it has classified very nicely mild, moderate, severe. All right. Important thing for mild, moderate, severe in Milwaukee is they have used carbon dioxide for their classification. While if you see SPAD and BSPAD, they have used bicarbonate less than 5, less than 10, less than 18 for SPAD, and for BSPAD less than 5, less than 10, and less than 15 for BSPAD guideline for severe, moderate, and mild respectively. So this information you don't need to mug up. It is easily available in the internet. So you can just download SPAD guideline, and all these things will be available. You can just take a printout and keep in your ICU for your reference. And we are just discussing the important differences. You need to know what are the important differences. There is one more thing called hyperglycemic hyperosmolar state. So in adults and in older adolescent children, we see this kind of problem where the pH can be above 7.3, not acidotic. Bicarb can be above 15, but still there can be severe hyperglycemia in the form of sugars of more than 600 and hyperosmolality of osmolality more than 320 milliosmoles per kg. So this is a very life-threatening condition, mostly in adults and adolescents. So what are the symptoms? As we already discussed, in mild DKA, you will see children coming with polyuria, polydipsia, weight loss, nocturnal enuresis. When it is moderate, apart from this, there will be additionally nausea, vomiting, abdominal pain, and in severe DKA, you will have decreased level of consciousness, small breathing, and fruity odor in the breathing, typical fruity odor of ketonic breathing. So ketonemia, how do you diagnose? The recommendation is you need to measure beta hydroxybutyric acid, and as we discussed already, when it is more than 3 millimoles per liter, then we say it is ketonemia. Okay, and studies have shown that when your bicarb is around 18, it corresponds to beta hydroxybutyric acid of 3. When it is 15, it corresponds to around 4.4. But generally we don't do it because it is a costly investigation. So what we do normally is we check the urine ketone because it is very easy. By dipstick method, you can do it at the bedside and you can do it multiple times. But there are problems with ketone, urine ketone, because beta hydroxybutyric acid is the main thing, which is 75% of the total ketones. And if you just check the urine ketone, it is going to underestimate that. So what happens is, many times in DKA you will see patient comes out of DKA in 24 to 48 hours, but because this beta hydroxybutyric acid has been converted into acetoacetic acid, that will continue to be excreted in urine for next 4 or 5 days. So urine ketone will be positive. So you may think that child is still in ketosis. So that you need to understand, and for that you need to check in the blood gas the anion gap. If your anion gap is normal and urine ketones are positive, ignore urine ketone. This may be just spurious value. If your anion gap is normal, that means that patient has recovered from decay. That important thing you need to understand. Now, how to manage? Before 1921, when insulin was not discovered, the mortality of DKA was almost 100%, more than 95%. Then insulin was discovered in 1921, as we know, and the mortality came down by 50%. And then high dose insulin regime reduced the mortality further. Then 1970s to 1990, people understood the importance of not just insulin, but also importance of proper fluid therapy, and mortality reduced to 10%. In 1990 to 2000 period, even more smart ways of management of fluid therapy and insulin therapy reduced it further, and presently the mortality is less than 1%. So much advancement happened because of our better understanding in how to adjust our insulin and fluid therapy. So what are our goals? Our main goal is correction of acidosis. Remember, in diabetic ketoacidosis, goal is not to correct blood sugar. The goal is to reduce the ketones in the body. So even if the sugars are still 400, 500, you will continue even if your sugars are less than 100, hypoglycemia, you will continue insulin infusion till your acid in the body is corrected, till your pH is above 7.35. That is very important to remember. All right. So you have to correct your dehydration and you have to prevent various complications of DKA. So acute management, ABCD, you must have attended all your PALS courses and your BLS courses. So airway, breathing, circulation, all these things you have to attend, and you have to get a peripheral IV access, a good IV access right away. Check your sugars, blood ketones, blood gas. It's very important. Take a proper history. Studies have shown that when you look at clinically and when you do lab tests, there is very little correlation between them when you are diagnosing severity of dehydration. That is why don't go just by clinical, do some lab tests also, and a combination of that is what is recommended to come to a conclusion of whether it is mild dehydration or moderate or severe dehydration. So lab tests basically do urea, nitrogen and ABG. So if you go by SPAD, it has been divided into mild DKA corresponding to dehydration of 5%, moderate DKA corresponding to a dehydration of 5 to 7%, and severe DKA corresponding to a dehydration of 7 to 10%. This is what SPAD says. BSPD guideline says that mild to moderate DKA corresponds to 5% dehydration and severe corresponds to 10% dehydration. Generally speaking, in our ICU, anybody who comes with a pH of less than 7.1, that is severe DKA, always take as a 10% dehydration and manage. Alright? So, how to manage? There are two possibilities in DKA. Patient is in shock, patient is not in shock. Most of the time, DKA is not in shock. Why? Because there is hyperglycemia. Because of hyperglycemia, as we discussed already, osmolality is higher in the plasma. So the fluid is shifting from intracellular compartment to intravascular compartment. So intravascular volume is always well maintained. So usually they are acidotic, maybe some dehydration, but they are not in shock. So this is the common situation where they are in volume depleted, but they are not in shock. And you usually get away with just 10 to 20 ml per kg bolus over 20 to 30 minutes. In rare cases, they may be in shock. If there are too many vomitings, child is really very badly dehydrated, severely dehydrated, in that case, you will have to give 20 ml per kg bolus as quickly as possible. This is as per SPAD. What BSPD says is, if there is no shock, give 10 ml per kg over 30 minutes. If there is shock, which is rare, give 10 ml per kg over 15 minutes. At the end of bolus, assess for how the patient has responded to your bolus. If shock is still there, give one more bolus. At the end of every bolus, keep assessing. Once you finished giving more than 30 to 40 ml per kg boluses, you can think of starting inotropes. Okay, this is again a very important randomized control trial which was published in NAGM in I think 2016, a very important study 2018, and this was a 2 by 2 factorial design where they compared 0.9% and 0.4% sodium chloride and rapid versus slow correction, and they interestingly found that neither the rate of administration, rapid versus slow, nor the sodium chloride content 0.45 versus 0.9% significantly improved the neurological outcome in children with DKA. Very interesting. So that means you go by slow correction or rapid correction, doesn't matter. That's why no need to hurry, correct it over 24 to 48 hours. Alright. So subsequent fluid management is usually again accomplished by 0.4 to 0.9% saline. Use ringer lactate or plasma light also. You can, if you don't want to give too much chloride. We will see in the next slides why I'm saying that. And then deficit you should calculate separately. So now there are 2-3 options which you have. Milwaukee will ignore. As per ISPAD, what you are supposed to do is, as I said already, first you give around 10 ml per kg as a bolus over 30 minutes. After that, you start correcting fluid therapy, correct? So that bolus which you give, as per ISPAD guideline, you remove it from your final calculation. BSPD says that if you are not in shock and you gave 10 ml per kg, you should remove it. But if you were in shock and you gave 10 ml or 20 ml per kg bolus, whatever you give, don't remove it from your final calculation. So, for example, if you have a 20 kilo 6-year-old child with 7.15, that means moderate DKA, and that is why you gave 10 ml per kg bolus, that is around 200 ml fluid you gave, then because it is moderate DKA, you will take 7% as your degree of dehydration. For 7%, you will take fluid calculation 7 into 20 and you will add one more zero, so 1400 ml. This is your fluid deficit. Remember, deficit is always given over 48 hours. Okay, and as per ISPAD, what did I say? Whatever bolus you gave, you have to remove it. So you gave 200 ml bolus here. So that out of 1400 ml, 200 ml is removed. So you are going to give 1200 ml over 48 hours. Okay. And maintenance is calculated from holiday cigar formula, and this is run over 24 hours. So this 25 plus 62, 87 ml per hour will be given for next 24 hours. Next 24 hours, again, this 62 ml per hour will be added. Alright. This example is also given in ISPAD guideline. Okay. You don't need to mug up anything. Now, there is another option, 15-year-old child, 60 kilo weight, this child is in shock. So as I said, if you are in shock and if you are giving a bolus, then this bolus is not subtracted as per BSPD. So if you have a 60 kilo, there is a severe dehydration and 6.9 pH, so you take a deficit of 10%, 60 kilo will be 6000 ml. You are not going to remove any amount from here. So this will be 125 ml per hour. Maintenance as per holiday cigar formula comes to 96 ml per hour. So now this patient will be on 125 plus 96 ml per hour to 220 ml per hour. This is the fluid calculation for this 24 hours. Next 24 hours, you will continue this 125 ml per hour because this is over 48 hours, and for next 24 hours, add this 96 ml for next 24 hours. Alright. So deficit is given over 48 hours. Maintenance fluid is continued as per maintenance. That's very simple. Urinary losses are usually not replaced. Obese children, you don't need to take ideal weight, whatever present weight, you need to just take the present weight. Coming to insulin therapy, insulin is never started immediately as soon as DKA patient comes in the emergency room. Remember that. So first you start fluid therapy, and how to start fluid therapy we discussed already. 10 ml per kg you will give. After that, you will calculate deficit and maintenance and start deficit over 48 hours, maintenance over 24 hours. Alright. And don't worry about that whether to remove deficit or not. Even if you don't remove deficit, doesn't matter. Alright. Now insulin, there are two options. One is 0.05, another is 0.1. Alright. Generally, for severe DKA, you start with 0.1 unit per kg per hour. For mild to moderate DKA, start with 0.05 unit per kg per hour. Alright. So this is what is the recommendation. This is an interesting study from PGI Chandigarh comparing 0.05 versus 0.1 unit per kg per hour, and they found that low dose is not inferior to standard dose for mild to moderate. So this is what I was saying. For mild to moderate DKA, use lower dose 0.05 unit. For severe DKA, use 0.1 unit per kg per hour. Subcutaneous insulin, we never give subcutaneous insulin in patients with DKA, so leave it. Now, potassium is very important. As I told you, all DKA patients will have intracellular hypokalemia. Even if you check serum potassium and it is normal, don't get fooled by that. The moment you start insulin, you will see the potassium dropping very rapidly. That is why if somebody is already having hypokalemia at the time of admission, remember, any acidosis increases serum potassium. We all know that, correct? So, if a patient is acidotic in DKA and with hypokalemia, it's very dangerous. Because the child is expected to be hyperkalemic and child is hypokalemic. That means imagine how much hypokalemia child may be actually having, isn't it? So that has to be immediately corrected. Right from beginning, you have to start volume expansion. If it is less than 3.5, don't start insulin. First correct your potassium, then you start insulin. Because the moment you start insulin, insulin will push potassium inside the cells and that will lead to sudden drop in hypokalemia, child will get into cardiac arrest. So you correct this potassium and then you start your insulin infusion. If you have a normal potassium, then you just need to add 40 milliequivalents per liter of insulin in your normal maintenance IV fluid. If there is hyperkalemia, which is possible because of acidosis, in that case you wait for urine output. If your urine output is nicely coming, then you can start 40 milliequivalents per liter of potassium in your maintenance IV fluids. Coming to phosphate, hypophosphatemia is also a big problem in DKA and this needs to be corrected, and sometimes you may have to actually stop insulin therapy, correct phosphate and then start insulin therapy once again. Now, whether rapidity of correction helps or not, this one is interesting study which was published in 2021 very recently, and it showed that you correct fast or you correct slow, it doesn't really matter. So that is why correction should be over 48 hours. Hyperchloremic acidosis, I already told, this is a problem because you are using saline. You are using 0.9% saline for your bolus, your IV fluid correction, maintenance, deficit. So naturally you are providing 155 milliequivalents per liter of sodium and chloride in the fluid. So that will lead to hyperchloremia, and hyperchloremia will lead to normal NN gap acidosis. And it's a constant problem. In DKA patient, usually we see after second day, the patient has come out of DKA, an N gap has become normal, but the pH is not improving. So that is because of usually hyperchloremia. So you need to interpret it quickly, and what you can do, usually it is asymptomatic in most of the cases. So what you need to do is just provide IV fluids which are poor in chloride. So give something like Ringer lactate or plasma light. So they are poor in chloride, they are deficient in chloride. Bicarb, never try to give bicarb in DKA unless and until there is real emergency. Somebody coming with a pH of 6.8, 6.9 and there is a cardiac depression because of severe acidosis, child is in hypotension, then you may give soda bicarb just to correct that pH. Otherwise, routinely soda bicarb should never be given in patients with DKA. It is dangerous. Why? Because soda bicarb, as soon as you give, it will produce the carbon dioxide. The carbon dioxide released will enter the blood-brain barrier and it will lead to intracerebral acidosis, and that will lead to worsening of cerebral edema. That's why it is dangerous. So when do you think about stopping insulin? Insulin is never stopped just because your blood sugars are normal, remember. The moment you start insulin infusion, within 6-7 hours you will see the sugars which the patient came with sugar of 600, after 8 hours the sugars may become 100, 150. You will not stop insulin just because sugars are 100 or 150. If the acidosis is going on, you will continue insulin therapy till your pH is more than 7.30, bicarb is more than 18 millimoles per liter, and your beta hydroxybutyric acid levels are less than 1 millimole per liter, or if you are not able to measure this, just look at anion gap. If your anion gap is less than 12, normal anion gap, that means you can safely stop your insulin therapy. Okay, the studies have shown that most of the severe DKAs usually take around 15 to 18 hours to correct. So that is a rough time. So when your patient is admitted, you can counsel the family that it's going to take around 24 hours roughly to get over the problem of DKA. Of course, you have to solve the original problem also. The patient may have come with some pneumonia or sepsis or gastroenteritis which has led to this DKA. If you don't solve the primary problem, the original reason for the DKA, then it may take a little longer time. So how will you monitor? Very close monitoring, child needs to be in the ICU. DKA patient cannot be managed in the ward. Earlier BSPD ISPAT definitions guidelines used to tell to manage mild DKAs in the ward, but now even ISPAT guidelines are recommending every patient should be admitted in the ICU and they should be managed in the ICU with every 1 hourly close monitoring of the temperature, pulse, respiratory rate, Glasgow Coma scale for sensorium. All these things need to be closely monitored. Every 2 to 4 hourly, you are supposed to monitor serum electrolytes, blood gases. Many patients ask, why are your hospital so costly? Why are you doing so many investigations? This is recommended, it is required, because if you don't do electrolytes and ABG every 2 to 4 hourly, you will not know where is your potassium going, where is your chloride going, and where is your pH going. And then you will not be able to titrate your insulin properly, and child will land up into cerebral edema and other complications. So that is important. As I said, beta hydroxybutyric acid we don't do in our unit because it's costly investigation. You can at the bedside manage with simple. In the ABG you can look at the Anand gap. Okay. So Anand gap, we know this is a simple formula for Anand gap. Normally it is 12 plus or minus 2. And once Anand gap is normal and you are still in acidosis, always think about hyperchloremic metabolic acidosis. Coming to the last thing, cerebral edema. Cerebral edema is a big problem in DKA, although it is not common nowadays because we are smart now in managing patients. So the incidence is hardly 0.5 to 0.9%. But when it happens, then the mortality is as high as almost 25%. So you should avoid cerebral edema. Previously, people used to think that it is because of idiogenic osmoles. But now the exact mechanism still people don't know. Idiogenic osmol means if there is hyperglycemia and excess amount of sugar in the blood, the osmolality, as we discussed, increases in the blood. To counter that, the brain and astrocytes in the brain and the neurons in the brain, they produce idiogenic osmoles inside the neurons and the astrocytes to counter the osmotic gradient between the extracellular and intracellular space. And the moment you start IV fluid and insulin infusion and everything, you are bringing down your blood sugars rapidly. Then what's happening in the extracellular compartment? You are bringing down the osmolality very rapidly. So when the osmolality is falling outside and intracellular osmolality because of idiogenic osmoles is still high, then what will happen? The fluid from low osmolality will shift from to the high osmolality, that means from extracellular to intracellular compartment, and this will lead to edema of the neurons and the astrocytes, leading to cerebral edema. This was a very popular hypothesis which was propagated, but now it is shown that it is may not be the reason. So people are saying now, the recent studies are showing that maybe it is the cerebral hypoperfusion, excess amount of hyperventilation due to severe acidosis. When the child is hyperventilating, carbon dioxide levels are below 20, that leads to severe spasm in the brain of the cerebral circulation. That may lead to ischemic injury to the brain, and also hyperinflammatory state overall can lead to damage to the nervous system. So the degree of cerebral edema that develops in DKA correlates with the degree of dehydration and hyperventilation, younger age, first time DKA, and increased urea nitrogen at the time of presentation, more severe acidosis. These are some reasons, lots of reasons people have given. Exact cause we still don't know. Now, when to start oral fluid? As soon as child is awake and able to take oral feeding, even with some acidosis going on, we can start oral feeding, and subcutaneous insulin should be started usually 30 minutes before you plan to stop insulin infusion. And always one more thing commonly we see is you stop insulin infusion, but IV fluids are still running. So if IV fluid is still running, the child will go back into DKA after 6 to 8 hours. Many times this happens that the nurses or the doctors forget to stop IV fluids. So because IV fluid is full of glucose, if it is dextrose containing IV fluid running and you stop the insulin, what will happen? Child will go back into DKA. So once insulin infusion is stopped, everything must stop. So all DKA patients, we will hang 3 bottles. One will be plain saline. There is no glucose. One is DNS with 5% dextrose. And the third bottle is 10% DNS. And you are monitoring sugar every 1 hourly. You will allow sugar to fall only by 50 to 100 milligrams every hour, not faster than that. Once your sugar is More than 300, you will allow only plain normal saline infusion, whatever deficit or your maintenance plate. Once your sugar is less than 300, above 150, 150 to 300, you will change plain saline to DNS, 5%. Once your sugar is less than 150, you will start 10%. So you keep playing between these three bottles all the time. Every 1 hourly check sugar, every 1 hourly decide this bottle or this bottle or this bottle. Sugar less than 150, 10% dextrose, 150 to 150 to 300, 5% dextrose, more than 300, plain saline. And as I said, if the chlorides are going high, you can go for 0.45% saline or ringer lactate or plasmalite. So that's how you keep going. This is called 3-bottle technique. That's how we manage all our DKs. And the moment you decide about stopping insulin infusion, you have to remove all these 3 bottles. Child should not be on any insulin infusion, only subcutaneous insulin, 30 minutes prior to stopping IV insulin, and then stop everything. That's how we do. So to summarize, successful outcome will depend upon your early identification. You have to identify DK early. Many times it is identified too late. And most important thing is very close monitoring by experienced and well-trained team of doctors and nurses to prevent complications like cerebral edema, hypernatremia, hyponatremia, hypokalemia, and all that. Thank you.
Well presented.
Thank you, sir.
Excellent talk. It's a very important topic for pediatrician. Of course, diabetic ketoacidosis, earlier said moderate is very high.
Yes, sir.
Now I think less than 1% we manage well. And of course, most of the pediatric diabetic type 1, they present DKA.
Yes, sir.
They present DKA. Most of them come with rapid breathing. Sans zyada kar raha. Where we were different diseases, asthma, it is some pneumonia, sometimes history have to take. So just ask history. पेशाब ज्यादा कर रहा, पानी बहुत पी रहा हूँ, उल्टी ठीक है. So carcinogen, there is no cough. Only they have more, taking more fluid for the past 3-4 days, passing more urine. Will failure to thrive, always think of DKA. Diagnosis is very clinical. Not suspect, but very important. As you said, correction of regulation should not be rapid. Of course, shock, correct. 10-20 we give. Once stabilized, don't push more fluids. So it will cause cerebral edema. So correction for particular is safe. And also one more thing, potassium is normal investigation. When you start insulin, potassium starts coming down. Where you have to give potassium. And one more thing is severe acidosis, don't use soda backup. Low acidosis, give soda backup, you will cause more harm. There is no role of soda backup because the dehydration correction is more important. Automatically acidosis comes down. Main thing is fluid. As you said, above 300, no, then no. Only normal saline, 150 to 100, 250, 5%, less than 100, 150, 10%. Hypoglycemia more dangerous than hyperglycemia. Hypoglycemia should be hypoglycemia, suddenly you don't current monitor, just give normal saline, give insulin, then go hypoglycemia, we can get very dangerous. So that's why I said, you have to monitor blood sugar, monitor electrolytes, and BP. I think it's well said, sir. Excellent talk. I think it's very practical also.
Thank you, sir. Thank you.
No child should die speaking.
Thank you, sir.
Thank you.
Thank you, sir.
Great presentation, sir. I noticed there are 3 situations where DKA patient will be only mild in cirrhosis, and other condition is when patient hypoglycemia is corrected, but cirrhosis persists. Other situation is where both cirrhosis and blood sugars are controlled, but acidosis persists. So how do we approach this?
Yeah. So as I said, sir, ketosis, where is it presenting? If it is urine ketones, it can be just a spurious ketoacetate. It may not be beta hydroxybutyric acid actually, because beta hydroxybutyric acid gets converted into ketoacetate and keeps getting released in the urine for 4-5 days. Patient has come out of DKA, pH has normalized. So if the pH is normal, bicarb is more than 18 and an anion gap is less than 12, and urine ketones are positive, I will ignore it. I will just ignore it. That is about persistent ketones. Second question was if the ketones are mild and the acidosis is still going on, there are only 2 possibilities. Either there is a sepsis along with decay. So then I will need to look at lactate, fever, there will be fever, lactate is elevated. Then you think about sepsis, infection that is causing persistent acidosis. There again your anion gap will be little on the higher side. Or if your anion gap is normal, no fever, no lactate, nothing, then it can be hyperchloremic acidosis. So look at chloride and manage with chloride.